Hey everyone! The time right after childbirth is amazing, but it's also a period where things can go wrong, and fast. So today, we're going to draw a clear, visual map of the biggest postpartum complications. The whole point here is to walk through the why, the pathophysiology, so you can actually picture what's happening inside the body. This is how you make these ideas really stick, not just for exams, but for real-world practice.
All right, so here's our game plan. We're starting with the number one most immediate threat. From there, we'll become detectives and figure out what's causing all that bleeding. Then, we'll see how that bleeding can snowball into systemic shock. After that, we'll switch gears and look at the next big threats, infections, and, you guessed it, dangerous blood clots.
So, first things first. In any clinical setting, you have to know what to worry about most. In those first few hours after a baby is born, one danger absolutely towers over everything else.
Let's just put it out there. In those critical first hours, what's the one thing that can turn a celebration into a crisis in the blink of an eye? You got it. It's bleeding. Massive, uncontrolled bleeding. And we have a name for it. Postpartum hemorrhage, or PPH. Now, this isn't just a little bleeding. We're talking about very specific amounts. More than 500 milliliters, that's half a liter, after a vaginal birth, or over a full liter after a C-section. But look at that last point because it's everything. The absolute highest risk white-knuckle period is the first 4 hours after delivery. That is your window for maximum vigilance.
Okay, so if hemorrhage is the big bad wolf, we have to know where it's coming from. So let's trace the bleeding back to its source, figure out the why.
The vast majority of the time, the culprit is one thing: uterine atony. It sounds complicated, but atony just means no tone. The uterine muscle is supposed to be firm, and it's not. It's failing to do its most important job.
Okay, I want you to really visualize this because it's key. After the placenta comes out, it leaves behind a wound inside the uterus about the size of a dinner plate. And that wound is full of huge open blood vessels. The only thing that stops a massive hemorrhage are the muscles of the uterus itself clamping down hard, like a powerful built-in tourniquet. When that uterus is boggy, soft, and mushy, that tourniquet fails, and those vessels just gush blood.
And this right here, this is our direct counterattack. Fundal massage is not a gentle rub. It is a direct physical command to the uterus. You are manually grabbing that muscle and forcing it to contract, forcing it to clamp down on those bleeding vessels. You are literally stopping the hemorrhage with your own 2 hands.
But what if the uterus feels firm, but your patient's vital signs are starting to look scary? Well, you have to think about our next cause, a hematoma. This is totally different. This is hidden bleeding. A blood vessel was damaged during delivery, and now it's leaking blood into the surrounding tissue, forming this painful, swelling collection of blood that you might not even see.
So, with a hematoma, the number one clue isn't always a pool of blood. It's pain. We're talking severe, out-of-proportion pain that pain meds don't touch. The patient might say they feel intense pressure, like they have to have a bowel movement. If you hear severe pain and you see a rising heart rate, you better be thinking hematoma.
Right, so whether the bleeding is obvious from atony or hidden in hematoma, if it doesn't stop, it leads to the same terrifying place, hypovolemic shock. Let's map out that path and see how the body completely breaks down.
It's a domino effect. First, you lose a ton of blood. That means, step 2, there's less blood volume circulating around your body. So what does your body do? It panics and tries to compensate. The heart starts beating faster and faster to push what little blood is left around more quickly. But eventually, there's just not enough volume to go around. The compensation fails, and the blood pressure plummets. That's the crisis.
And this right here, this is probably the most important thing you'll hear today. A drop in blood pressure is a late, oh my gosh, we're in trouble sign. The very first, most subtle clue that your patient is bleeding internally is a rising pulse, tachycardia. That heart is screaming for help long before the blood pressure falls off a cliff.
All right, so once we get past that immediate, terrifying threat of hemorrhage, a whole new set of dangers pop up. The body is wide open after birth, and it's a perfect invitation for infection to come marching in.
2 of the most common ones you'll see are endometritis and mastitis, and telling them apart is actually pretty simple. It all comes down to location. Endometritis, that's an infection inside the uterus, usually right at that big placental wound site. Mastitis, that's an infection in the breast, typically from a clogged milk duct. Uterus versus breast. Simple as that.
Now, for endometritis, all the signs point to a deep infection in the uterus. The classic telltale sign is a fever over 104 degrees.
But here's the kicker, it shows up after the first 24 hours. A little fever on day 1 can be normal, maybe from dehydration, but a higher fever on day 2 or 3, that screams infection. Plus, you'll get the chills, a really foul-smelling discharge, and a tender, painful abdomen. Mastitis, on the other hand, is way more localized. You can usually see it. It looks like a red, swollen, hot, painful wedge on one of the breasts. The patient will feel awful, like they have a terrible flu, but the root of the problem is right there in the breast tissue.
Okay, now the most important intervention here can feel a little weird, but it is absolutely critical. You have to keep emptying that breast. The whole problem started with a blockage, right? So you have to clear it. Continuing to breastfeed or pump is key to getting better, on top of antibiotics, drinking tons of fluids, and other comfort measures.
And finally, let's talk about our last major threat, blood clots. Pregnancy itself makes blood clot more easily to prevent hemorrhage during birth. But that risk doesn't just vanish. It sticks around into the postpartum period.
It all starts with something called thrombophlebitis. That's just a fancy way of saying a blood clot, a thrombus, has formed in a vein, usually one of the deep veins in the legs. This is ground zero for a potentially fatal chain reaction.
And this slide maps out that horrifying journey. So the clot's just sitting there in the leg. The real terror begins when a piece of it breaks off. Now it's not a thrombus anymore, it's an embolus, a clot on the move. It travels up through the veins, right through the heart, and gets pumped directly into the lungs, where it gets jammed in a pulmonary artery. That, my friends, is a pulmonary embolism, or PE, and it's a code blue level emergency.
The signs of a PE are not subtle. They are sudden and they are dramatic. Your patient will suddenly grab their chest in pain and gasp that they can't breathe. Their heart rate and breathing rate will go through the roof. And you have to pay attention to that last one, a feeling of impending doom. It's a real textbook symptom. When your patient looks you in the eye and says they feel like they're going to die, you believe them. Every time.
So, when you boil it all down, what's our job? It's being a good detective. It's vigilant assessment. Every single one of these catastrophic events starts with a small, subtle clue. A rising pulse for a hemorrhage, pain that's way worse than it should be for a hematoma, a sudden fever after that first day for an infection, or that sudden, sharp chest pain for a PE. Catching those clues early on is the whole ballgame.
So I'll leave you with this question to think about. You're walking into your patient's room. You have all these dangerous pathways we've just visualized in your head. Which one of those tiny, subtle signs, that little blip on the radar, is going to make you stop everything and act first? Answering that? Well, that's the heart of being a great clinician.